All right, so we are going to go over chapters 6 through 10 of our textbook, and this is primarily focusing on antepartum nursing care. So that is care of the mother before she delivers, before labor, before delivery. We'll start with chapter 6, which is the genetics, conception, and fetal development. Okay, so going over genes and chromosomes. So DNA forms thread-like strands known as chromosomes. The hereditary material carried in the nucleus of each of the somatic cells determines each cells and each individual's characteristics. So each chromosome is going to contain smaller segments of DNA called genes. Genes are a combination of gene-contained code information which determines an individual's unique characteristics. So your genes are going to determine the individual characteristics of a person. A normal human cell contains 46 chromosomes. 23 of these are coming from the sperm and 23 are coming from the egg. You have 22 pairs of autosomes and one pair of sex chromosomes. The X chromosome always comes from the ovum, and then your sperm carry the X or the Y chromosome. So the sperm is what is going to determine the gender of the fetus. So an XX chromosome is a girl, XY is a male. And then you're going to want to know the difference between a genotype and a phenotype. Your genotype is the genetic makeup of an individual whenever you're discussing a specific gene pair. But this is sometimes used to refer to an individual's entire genetic makeup or all of the genes that an individual can pass on to their future generations. Meanwhile, a phenotype is the observable expression of an individual's genotype, such as like physical features, a molecular trait, psychological traits occasionally too. So yeah, know the difference between your genotypes and your phenotypes. Whenever we're talking about chromosomes and traits, we also need to talk about dominant and recessive traits. This concept has become a little bit more complex, and it's specifically a little more complex in like the X-related and X-linked disorders. So a trait or a disorder is considered dominant if it is expressed or phenotypically apparent when only one copy of the gene is present. And then it would be considered recessive if it is expressed only when two copies of the alleles associated with the trait are present. So traits considered recessive may be expressed even when only one copy is located on the X chromosome. So this is common in males because they only have the one X chromosome. Whichever gene is present on the X chromosome is determined whatever trait is expressed. These concepts are a little bit confusing. So like definitely refer to your textbook because it goes into it in a lot more detail than I'm going to get into on these slides. I'm just kind of hitting on like the really big points. Whenever we're also discussing gene makeup and development, we have to talk about chromosomal abnormalities. These are a major cause of reproductive loss, congenital problems, and gynecologic disorders. And most of these abnormalities are occurring due to during cell division, if there's any type of damage that occurs during the cell division. So during mitosis or meiosis. So mitosis is the cell division occurring in somatic cells, which result in two identical daughter cells. And then meiosis is a division of a sex cell into 2 and 4 haploid cells. So whenever you're talking about chromosomal abnormalities, these happen a lot of the time during cell division, which is an important point to know. Excuse me. Autosomal abnormalities involve differences in numbers or structures of autosome chromosomes. So this is when we're getting into like trisomy 21, 18, and 13, which is your Down syndrome, Edwards syndrome, and the Pitot syndrome. So I have a little chart here that kind of shows the differences between each of these syndromes. I'll go into them in a little bit more detail here too. So trisomy 21 is Down syndrome, which is very common. We see this quite often, especially in certain patient populations. A clinical presentation can be complex and it can be variable. So as a labor and delivery nurse, if you're assessing an infant, sometimes it's hard to tell if an infant has Down syndrome, especially if the parents didn't do the complete genetic testing panel that
You're
you.
so welcome. You're so welcome. That should last you like at least 3 months. So
Do you have a question? Oh, okay. So, in early pregnancy, you can have a genetic panel done, which can tell the likelihood of an infant having trisomy, any of the trisomies, or any type of genetic abnormality. If a patient opts not to do this, which is not uncommon because this genetic testing is typically not covered by insurance and it can cost like $300 to $400 out of pocket. So some patients aren't going to opt to do this testing. Um, if there's no testing available, sometimes you can't confirm whether or not a child has Down syndrome until they're a little bit older and they're seen by their pediatrician. But um, some like physical characteristics that can be seen in trisomy 21 would be a flat facial profile, enlargement of the tongue, small ears of abnormal shape or location, short, broad hands, muscle hypotonia, and hyperflexibility. Um, they infants and individuals born with Down syndrome also have a high rate of congenital heart defects. They also will have sleep apnea just because of the structure of their facial features, that flat facial profile. Um, and they're also prone to like otitis media and then eye disease. And this is also just because of their anatomy and their structure. But like I said, as a labor and delivery nurse, if you're immediately assessing a newborn, it can be really difficult to tell. And oftentimes the infant will need to undergo some further testing or some further assessment. Trisomy 18, which is Edwards syndrome, is a lot less common. It only occurs in about one in every 6,000 live births. Compared to Down syndrome, that's a lot less common. Individuals born with this have severe intellectual disabilities. They also have a lot shorter life expectancy than infants or individuals born with trisomy 21. Um, However, it's not also uncommon to see these infants living until their 20s or 30s. As far as their medical complications at delivery and their physical assessment, they're going to be very small for gestational age. They're also going to have some craniofacial abnormalities. So these infants can be born with cleft lip or palates, small mouth and jaw. They're going to have a weak cry. These infants are not going to feed well, especially if they have a cleft palate. With cleft palate babies, there are special feeding tools that you should implement to be able to ensure that they're getting proper nutrition. And sometimes that's not um, breastfeeding. You have to use different methods, and um, their feeding is going to be a little bit different. There also have some cardiac malformations. They're going to be hypertonic compared to Down syndrome babies, which are hypotonic. These babies are also prone to seizures. Um, they have the microcephaly, so they're small, like shrunken heads, an absent nasal bridge, and then some extremity deformities. So these babies will often be born with like an extra finger, an extra toe. They'll have some, which is polydactyly. They'll have a couple abnormalities as far as like limb structures. And then the last one that I have listed there, trisomy 13, it occurs even less frequently than trisomy 18, which is it occurs in about one in every 16,000 live births. Yeah, so I would definitely make sure you guys know the difference between these three and know the physical structures and the abnormalities that can be associated with these infants at birth and the things that you would notice as a nurse, okay? So we're going to be moving on here to multifactorial and, sorry, one second, unifactorial inheritance. So multifactorial inheritance, this is resulting from two or more genes on different chromosomes that are acting together. This is most common way that congenital malformations are the most common way that congenital malformations or these things happen is from environment and genetic factors. So this is factors such as like a mom or dad's diet, lifestyle, any exposure to toxins, geographic influences. Medical interventions can also trigger or modify a person's genetic risk. Um, and then also like any type of clinical severity, how severe, if there's any like severe underlying medical condition, anything like that. Um, you are not able to screen for multifactorial congenital malformations. So like cleft palate, congenital heart disease, any neural tube defects, these kinds of things. Um, are difficult to screen for and are often due to like diet, lifestyle, any toxin exposure, things like this. Unifactorial inheritance is controlled by a single gene. It's mostly dominant and recessive genes, and there are carrier testing that you can do for these specific ones. The affected individual, this can come from multiple generations of having disorder of this specific disorder. Um, this is kind of going on like autosomal recessive, X-linked dominant traits, X-linked recessive traits, and how they're passed. So I have this little graph over here that shows you like a carrier and a non-carrier, and the likelihood of their children being carriers or having the disease. This little graph is really helpful. There's a couple other charts and tables and stuff in the textbook that are a little bit more detailed as far as explaining the way that these genes and these conditions are passed from parent to child and who's most likely to be inheriting or being a carrier of something specific. So some non-genetic factors that can influence fetal development. These ones are really important, and it's also talked a lot about. We talk a lot to our patients about these things in their prenatal testing. So your environment, any infectious agents, mechanical problems, and any drugs or teratogens. So environmental factors, right? This is your alcohol intake. If a patient is a diabetic, if they're controlled diabetic, if they have high blood pressure before or chronic hypertension before they're getting pregnant, um, if they're smokers, and any other type of underlying nutritional problems. So I know in week one, we kind of went over, or the PowerPoint went over specifically like any eating disorders and how that can impact a pregnancy or impact fetal development. Infections would be like if the mom is rubella immune or non-immune, any toxoplasmosis, which is a really big one. We have to educate our patients on that. Um, any syphilis, HSV, any other type of sexually transmitted infections or STDs, that can also impact fetal development. Mechanical problems are getting a little bit more into the anatomy and the makeup of the placenta, fetal development. So, like if the mom is having any amniotic bands, any umbilical cord restraint or restriction, and then like uterine growth. So, making sure that the mom's uterus and the baby is growing in appropriate sizes throughout the pregnancy. And then chemicals and drugs are would be like if they're being exposed to radiation, what kind of medications the mom is on. Obviously, any type of recreational drugs or harder drugs or anything like that. If the mom has a history of anything, to be educating these patients and informing them that we need to stop or pause treatment or whatever it may be. So, kind of diving into fetal development. So, on page 156 on table 6.1, there's this really awesome graph that shows the baby's growth through weeks 1 through, I think it goes to 8. Sorry, it's really small on my screen. But this kind of shows like what the fetus is developing and how they're developing. And the typical growth points that you want to be meeting at each week of life. So the embryonic stage is 15 days until about 8 weeks after conception. This is the most critical time of the pregnancy, and it also has the highest instance of miscarriage. Um, And then after 8 weeks, we consider that the fetal stage. So that's 9 weeks of pregnancy and beyond. This is when all organ systems and external structures are present. And then the embryo is definitely human, and we're doing a little bit more testing, and the appointments are going to be a little bit more regular. Ultrasounds are going to be about every 4-ish weeks, depending on the mom's medical history and her and just in general how she is doing during the pregnancy. So I know this is kind of going back to week 1, but where does fertilization occur?
In the fallopian tube.
Yep. I'm just making sure you guys aren't sleeping on me. So yeah, correct. It occurs in the fallopian tube. So yes, this is a good graph if you guys want to refer to it in your text. My page numbers might be a little off because I'm not using the online textbook. I've been using the one like a hard copy that I have had. So if my numbers are a little bit off, I apologize, but it should be around these page numbers. Okay. So kind of diving into the amniotic fluid, um, important things to know are like when does the amniotic fluid become apparent and what are the big functions of the amniotic fluid? So can anybody list or tell me a couple of the functions of amniotic fluid?
Does it serve as protection?
Yes, definitely. So big functions of the amniotic fluid, it maintains your fetal body temperature. It is the source of oral fluid and repository for waste. It also assists in the maintenance of fluid and electrolyte hemostasis. And it also provides as a cushion or a barrier for the infant from external trauma. And it is basically what allows the appropriate fetal development, allows the baby to grow normally. So amniotic fluid is considered to be amniotic fluid in the second trimester, and it is regulated by a balance between fetal fluid production and then fetal reabsorption. Okay. I have here the guidelines between oligohydramnios, which is having too little amounts of amniotic fluid, which is less than 300 mLs. Um, One of the biggest things that you can see with oligo is fetal renal abnormalities. Um, these babies also sometimes will have like growth restriction. They're not going to be growing as well. Also, if the oligo is severe enough, moms will also be like induced earlier than what we like to see them grow their babies to, just because this can be like pretty serious. And then poly is whenever you have too much amniotic fluid or an excess amount of amniotic fluid, and that is more than 2 liters of amniotic fluid. And in the infant, this can cause GI and other malformations. Oftentimes, which I can't say all the time because that would not be true, but oftentimes, if a mom has an excess amount of poly, she has something else that is underlying that can cause that, right? So if your mom is a gestational diabetic, I would not be surprised if she also had polyhydramnios. We've seen that a lot before, where if a mom has failed her 1 hour glucose test and was testing her blood sugar, and say she refused her 3 hours, whatever, for whatever reason, and was checking her glucose at home, and she came in and we broke her water, and she just has a lot of fluid. So that is very common in gestational diabetics, is to have an excess amount of fluid. So this lovely picture over here is the placenta and the umbilical cord. So a very important thing to note is that an umbilical cord has 2 arteries and 1 vein. It is surrounded by a Wharton's jelly, which is the connective tissue that surrounds the vessels. This prevents compression of the blood vessels and ensures that the infant is being continually nourished. Your placenta, it begins to form at implantation. And then by the end of the 3rd week, there's a fetal heartbeat, and that is when your maternal fetal blood flow begins. The main function of the placenta is fetal nutrition and metabolic exchange. Um, it also will produce progesterone to maintain the endometrium. And then the function of it depends on the maternal blood pressure. So if a mom has high blood pressure or any type of blood pressure issues, placental function is going to decline pretty rapidly. So that's why we're maintaining and we're watching mom's blood pressure very closely during pregnancies, before and after pregnancy, because blood pressure has a huge impact on maternal fetal blood circulation and placental viability and overall just the function of your placenta. All right, so we're going to go over fetal circulation. So like I said, by the end of the 3rd week of gestation, the infant's tubular heart begins to beat. During the 4th and 5th weeks, the heart develops into a 4-chambered organ. And then the heart is fully developed by the end of the embryonic stage. So your fetal lungs do not function for respiratory gas exchange. So a special circulatory pathway, which is the ductus arteriosus, is formed, and this is going to bypass the lungs. So this is really important because the ductus arteriosus diverts blood from the fetal lungs, and it connects the umbilical vein to the inferior vena cava. So your oxygen-rich blood from the placenta is going to flow rapidly through the umbilical vein into the fetal abdomen. And when the umbilical vein reaches the liver, it divides into 2 branches. One branch circulates oxygen blood through the liver, and then most of the blood will pass through the ductus venosus into the inferior vena cava. There it's going to There, it mixes with deoxygenated blood from fetal lungs and abdomen on its way to the right atrium. And it'll make its way into the foramen ovale. And it's going to come mixed with deoxygenated blood returning from fetal lungs through the pulmonary veins. The blood flows into the left ventricle and squeezed out into the aorta. And this is where the arteries supplying the heart, head, neck, and arms receive most of the oxygen-rich blood. Deoxygenated blood returning from the head and arms enter into the right atrium, and this blood is directed to the right ventricle where it's squeezed into the pulmonary artery. So this is a lot, and seeing it on a graph is going to be a lot easier. So I didn't put it in this PowerPoint, but I'm going to attach it to your guys' like the week 2 announcement, where I have like a video of it showing like the blood flow, mom, placenta, baby, back out. So the biggest ones that you want to really focus on is the ductus arteriosus, which is what's diverting blood from fetal lungs, and your foramen ovale, which shunts blood from the left to the right atria. And then knowing which vessels carry oxygenated blood to the fetus and then deoxygenated blood away from the fetus. But definitely know that there is, let me go back to this one, 2 arteries and 1 vein that make up the umbilical cord, okay? That's going to be really important whenever you're studying for your tests. So here's another little image here of the ductus arteriosus, the foramen ovale, and then just like the blood flow through to baby and then out. Okay, does anyone have questions so far? We all still with me? Okay, I'm planning us to take a break probably around 3:30. So we'll just kind of keep working our way through this until then. So moving on to chapter 7. Let me take a quick sip of water real quick. 1 second. Which is the anatomy and physiology of pregnancy. So obviously in pregnancy, the mom is undergoing lots of physical changes. So first of all, the uterus, obviously it's going to expand in size and change shape due to increases in progesterone and estrogen. So some important things to kind of remember your definitions of are lightening, quickening, Braxton Hicks, and your Hagar sign. So lightening occurs between 38 and 40 weeks. The fundal height decreases as the fetus begins to descend in the pelvis for birth preparation. Quickening is your first recognition of fetal movement, and that happens at different times for each mom, really, depending too on like what number pregnancy it is. and how obviously how far along they are. It can happen at different times for each mom. Braxton Hicks can occur as early as after the fourth month of pregnancy. And these are intermittent uterine contractions, which may be felt, but they are usually irregular and painless, and they stop with intervention. So, as a labor and delivery nurse, you'll have a lot of moms come in who are like, I'm in labor. This is what's happening. I've had contractions last hour. They're exactly 3 minutes apart. Um, and then you give them a little bit of fluid, you lay them on their left side, and their pattern will completely stop. The true signs of labor is usually indicated by cervical change. So, Braxton Hicks contractions can happen as early as 4 months into the pregnancy, and they're just kind of they're practice contractions, right? Your body has to practice before it does anything. You have to practice before you do anything. Braxton Hicks are what we call your practice contractions. So they're kind of preparing the body for labor. They're just not true labor. So if you're talking to a mom on the phone, you can be like, okay, drink a huge thing of water, lay on your left side, get in the shower. If they go away with that, it's not usually real labor. They're Braxton Hicks contractions. Your Hager sign is usually happens at 6 weeks of gestation. This is softening and compression of the lower uterine segment. This can cause increased urinary frequency. So your moms are gonna go pee all the time. Breasts are going to be changing. They're going to enlarge and become tender. A woman's nipples can darken in color and grow in size. They'll become heavier, a little bit more sensitive. They're preparing for lactation and being able to nutritionally provide for the baby. Your respiratory system. So in pregnancy, a woman's oxygen consumption increases by 20 to 40%. The enlarging uterus will push upward, will grow upward, and it places a lot of pressure on the base of the lungs. So pregnancy related dyspnea is common and happens as the woman's body is changing and that uterus is growing and kind of compressing on the lungs. GI, obviously, one of the biggest symptoms of pregnancy is nausea and vomiting. And then constipation. Constipation is due to a reduced amount of peristalsis, which is caused by your increase in progesterone. The important one for you guys to remember is hyperemesis gravidarum. This is when a woman physically cannot stop vomiting to the point that she is dehydrated and nutritionally depleted. This can be something that women are hospitalized for, and they're receiving Zofran as often as they can and having IV fluids given to maintain their hydration status. So that is something to definitely make note of because it can be pretty serious. As far as the urinary system, you're looking at increased frequency. Pregnant women are also prone more to urinary tract infections. So a lot of education with moms about adequate water intake, making sure you're relieving yourself as you need to, proper hygiene, all that stuff is really important to go over with these women because they are at an increased risk for urinary tract infections, especially if they were having them commonly before pregnancy. That will also cause them to potentially have more during pregnancy as well. For the skin, lots can happen with the skin. Common things are like melasma, which is that blotchy, brownish hyperpigmentation of the skin. And it's usually on like a woman's like cheeks, nose, forehead. Your linea nigra, which is your pigmented line extending from the symphysis pubis to the top of your fundus. It just goes like right down their belly. It's a darkened line that some women will get. And then striae gravidarum, which is the fancy medical term for stretch marks, which can happen on your belly, on your breasts, on your hips, anywhere really. Some women ask like if it's a genetic component, and there really hasn't been like a lot of studies or anything done on them. It's just something that is pretty common during pregnancy. Your musculoskeletal system, it's not uncommon to see a change in posture due to like your other weight shifting and changes. So sometimes like women also complain of like a lot of back pain. That can be because of where the baby is lying, the way that their body is changing and growing. So that is common. If they ask about like seeing a chiropractor, it is always best to refer them to their gynecologist. That is something, especially working with the Amish population. Almost every single one of my patients that I saw went to chiropractors. It's just a really big thing with them. So making sure that the person they're seeing is certified and that their OBGYN says that it's okay. The endocrine system, there's going to be a natural enlargement of the thyroid gland. Your pituitary gland will increase, so your insulin need will increase as well during pregnancy, which is why we do the glucose tolerance test, and also why we are checking TSH and T4 to make sure that thyroid function is adequate throughout pregnancy. It's not uncommon for your TSH to increase, which is signs of hypothyroidism during pregnancy, just because of the enlargement of the thyroid gland and the amount of hormone that the fetus is requiring. Neurologically, pregnant women are prone to headaches, lightheadedness, and some alterations in sleep. Insomnia is not uncommon in pregnancy. And then obviously, too, another thing that pregnant women will tell you is that they have an increase in fatigue in that first trimester. They're really, really sleepy. Usually that can lessen in the second trimester whenever your hormones are shifting. So I also put down here some references for information about hormone changes. And then there's also a really good table that kind of outlines all the other discomforts related to pregnancy. So a big one that we want to talk about, which is why it has its very own slide, are the cardiovascular changes. So in pregnancy, a woman's blood volume will increase by 40 to 50%. Likewise, their cardiac output increases by 30 to 50%. What kind of factors do you think will impact or could impact maternal blood pressure in pregnancy?
Age.
Yes, that's a big one. Age, definitely. What else do you guys think?
Smoking and drug use.
Yes, definitely.
Ethnicity.
Yes. Overall, too, like general lifestyle, right? So, what a patient's diet consists of, exercise level, if they have any underlying medical conditions, right? So if they already have underlying hypertension, they're going to have blood pressure issues in pregnancy. If they're taking certain medications that can impact their blood pressure. So like one that is kind of unique to hormones and cardiovascular stuff. So for acne, commonly what's prescribed can be spironolactone, which is a potassium-sparing loop diuretic. So ultimately, that's lowering your blood pressure, right? So spironolactone, though, is not safe in use during pregnancy. So if a woman is coming off of spironolactone because they can't take that, it's a class C, I think, medication, they can have some rebound hypertension because of the withdrawal from that spironolactone and the way that their body is adjusting and the shift in those hormones. So that is something to take note of. Like if a woman's never had issues with their blood pressure before, but they're coming off a specific medication, that can alter their blood pressure, that can alter the readings that you're having. Also, something you see is vena cava compression later in pregnancy. So what position is that usually, like what position do we tell moms not to lay in?
You want them to lay on the left side, right? Not the right.
Yeah,
Avoid like laying on their back.
Or something like that.
exactly. So both are right. So we don't want moms laying on their back because this can cause their vena cava compression syndrome. But we also encourage moms to lay on their left side because that is the best way that blood flow is going into the placenta. So that increases your placental blood flow. So yes, those are both correct. So there is a difference between supine hypotensive syndrome and vena cava syndrome. So supine hypotensive syndrome can occur in any woman who lies on their back during the second half of pregnancy. Um, um, CO is reduced by as much as 25 to 30% when a pregnant woman is turned from left lateral recumbent to supine position. So your cardiac output is going to decrease if they're in that position. So after 4 to 5 minutes in this position, you have just natural reflex bradycardia, and then your cardiac output is reduced in half. And that can cause a pregnant woman to feel faint, lightheaded, dizzy, just not very well. If you are monitoring that, say that woman is in for an NST or whatever, and she's laying on her back for a while and she's having symptoms, any type of symptom that a mom is having, like reflex bradycardia or hypotension, your baby's going to feel that too. So you would kind of see a little bit of fetal baseline change on your fetal heart rate monitor if mom's in a position that isn't encouraging or compatible with blood flow and oxygen flow to placenta and to the baby. Okay. So, yeah, a lot of education with moms. We pretty much tell them after 18 to 20 weeks, sometimes even earlier, not to be laying on their back, lay on their side. Definitely avoid putting pressure on their belly. So, laying on your belly is not an option either. So, we're like, get a really good pregnancy pillow because you're going to be laying on your side for most of this rest of your trimester for your term. The heart rate and rhythm naturally will increase, and they do have some slight enlargement of the heart during pregnancy. Physiologic anemia. So, because the plasma is increased in pregnancy rather than an increase in red blood cell production, there's a decrease in the normal hemoglobin and hematocrit values. So this increase in plasma and there's no change in the red blood cell production will cause hemodilution, which can cause a physiologic anemia. So this is kind of determined by hemoglobin that's under 11 or a hematocrit that's under 33%. That's the anemia criteria for pregnancy. Typically, what providers will do is, depending on what the hemoglobin and hematocrit levels are, they'll encourage oral iron intake, so changing a diet, or sometimes they'll have moms, if it's a little bit more severe, do monthly, weekly, whatever it is, Venifer infusions, where the mom will come to the hospital and get infusions to kind of increase her iron and combat that anemia. Women in pregnancy are also hypercoagulable. So we need to, as nurses, make sure we're giving really good education on, hey, you're at an increase for blood clots. That's just something that happens with pregnancy. So wear your compression socks if you're going to be on your feet for a long amount of time. If you're flying on a plane, there's nothing that says you can't fly on a plane. Just making sure you have your compression socks. You're getting up, you're moving, you're moving your feet around. Making sure we're staying really nice and hydrated, staying active, and then also going over in really good detail signs and symptoms of your DVTs. When women should go to the emergency department, how they can identify blood clots, and kind of what that looks like and what to expect with that. Okay. Any questions so far? All right, so chapter 8, nursing care of the family during pregnancy. So we're gonna go over gravity and parity because this is gonna definitely be seen on your guys's quizzes and exams. So make sure you kind of get this down. So gravity is the number of pregnancies regardless of your outcome. Okay, so even if a woman has had miscarriages, that is still a pregnancy. So you're counting that in their total pregnancy. So prima gravida, multigravida, nulla gravida. Prima gravida, we call them primips. That is a first-time mom, first pregnancy. Multigravida is multiple. This is not their first pregnancy. And nulla gravida means that they haven't been pregnant before. We also have grand multigravidas. That's not in your textbook. It's just something that I thought to add. And this is usually whenever women have, I think it's more than 6 like term pregnancies. And that will be referred to like grand multips. in the hospital. And then your parity is the number of deliveries in which the fetus reached 20 weeks of gestation. So this is like full-term infant deliveries. So if a mom comes in and she's had a history of 2 miscarriages and she's pregnant with her, and she's 38 weeks pregnant, what would her G's and P's be?
Say it one more time, please.
Yeah, she's had 2 miscarriages and she's coming in, she's 38 weeks pregnant with her 3rd pregnancy. What would her G and P's be? Kind of tricky.
G should be 3 and her P's should be oh Lord, I just wrote this down. And P and her P will be 2. Is
Her
it G3 P2?
She would be a G3P0.
P0. Oh,
So your P is usually like live children that you've delivered, infants that you've delivered at term gestation. So she had those 2 miscarriages, which count as a pregnancy, which would go under your gravity. So that would be 2. And then she's pregnant with a term baby that she's going to be delivering. So that would be her 3rd pregnancy, but she doesn't have any children living at home yet. So she's a G3P0. I think the next one goes into a little bit more detail. So yeah. So the whole one that we go by, if you're looking at a medical record that you're getting from like an OBGYN's office, they're going to go through each one of these sections. So a G, which is your gravity, term, parity, abortions, and then living. So your total number of pregnancies is that gravity. T is your term deliveries, which is considered after 37 weeks. Your parity is your P is preterm deliveries, which were between 37 but after 20 weeks. And then abortions would be like your spontaneous or terminated before 20 weeks. So miscarriages, elective abortions, that would fit under this category. And then your L's is living children. So when you're doing this, it splits up your parity and your living children, because the P and GTPL in this one is counting for preterm deliveries. So it gets a little confusing when you're looking at both of these side by side. But if you're just doing G's and P's, it's usually considering like your full term deliveries or living children that a woman might have. If you have twins, is that 1 or 2 pregnancies?
1.
Yes.
isn't it dependent on?
So that would be 1. So it doesn't matter what kind of twins. That's something people have asked before. So say you have a mono twin, a di twin. It doesn't matter what kind of twins they are. A twin pregnancy always just counts as 1 pregnancy. Okay, so you don't need to count the fetuses, you just count the 1 as far as for your G's. Okay, so as far as signs of pregnancy, we're gonna divide these into presumptive, probable, and then positive. Okay, because there is a difference. So presumptive is like subjective. So like things that a woman will notice that will kind of be like, maybe I'm pregnant. So breast changes, like I said, enlargement of the breast, nipple changes, stretch marks on your breasts, tenderness, hypersensitivity, those kind of things, missing a period. That is not always a surefire sign of pregnancy. Women can miss periods for a lot of different reasons. Hormone fluctuations. If they have thyroid issues, hypothyroidism patients, those patients sometimes will not have periods for months and months. PCOS. If a woman has PCOS, she might not have a period, or at least a regular period, for an extended amount of time. So periods are not always positive signs of pregnancy. Okay, a woman can have a missed period and not be pregnant. Nausea and vomiting, that too is a huge hormone component. So PCOS patients, all those underlying medical conditions can cause nausea and vomiting. That's not always pregnancy, 100% for sure thing. Urinary frequency, again, that is not a positive sign of pregnancy. That can just kind of happen occasionally. or if a woman has a UTI. So that's why you just be like, all right, what other kind of symptoms are you having? Let's go ahead and test to get a UA. Fatigue, that's subjective. And then that quickening, like I told you guys about, like those like slight movements, that is sometimes subjective. That can be a lot of different things, and it's not definitive and not something that we would be like, yeah, you're definitely pregnant due to that. Probable signs of pregnancy. So these signs that I have in here, I definitely would know the difference between those. Okay, these are important. Your Goodall sign is a softening of the vaginal portion of the cervix, and this is caused by increased vascularization. That's usually noted by an OBGYN. Like your patient isn't going to come into you and be like, hey, I have a Goodall sign. You know, if they know what that is, like they're probably in nursing school, but they're not going to come into the office and be like, yeah, this is what's going on. Your Chadwick sign, which is a bluish or violet discoloration of the vagina and cervix in early pregnancy. This is caused by an increased blood flow to the pelvic region. And then your McDonald sign is measuring the mom's fundal height in pregnancy. Okay, so fundal height changes, fundal height increases or changes. So these are all what we would consider objective signs, which is like, yeah, they're usually associated with pregnancy. There's not very many other things that would cause these things to occur in a woman, but they're also not like 100% definitive. Your positive signs of pregnancy are going to be attributed to the visualization or auscultation of the fetus. Okay, because and some people will say or argue like, oh well, if we have a positive pregnancy test or we have an increase in HCG levels, that is definitely a pregnancy related thing, but it's not, because different things can cause HCG levels to increase. Do you guys know what some of those things would be, or one of those things? So the most common one would be a type of tumor, like an ovarian tumor. Sometimes those kind of tumors can produce HCG levels, which can give a false positive pregnancy test. So really the only definitive positive way that we can determine a pregnancy is by visualizing or auscultating fetal heart sound, or seeing the fetus inside gestational sac in the uterus. Okay. Another one, which I actually just learned, which is super random, and it's just a fun fact, you're not going to be tested on this, is if women have ingested, say a woman has like a mouse in their house, they have mice. If a woman somehow ingests mouse droppings, that can also cause HCG levels to rise. I didn't know that. But my OBGYN was doing surgery on a patient who was like 65, and she had a positive pregnancy test. And she asked her, like, hey, do you have mice in your house? And she did. And I guess that can cause HCG levels to increase, which I thought was like kind of gross, because you're eating mouse droppings, but also kind of interesting. All right. So Naegele's rule, this you guys will definitely want to know, is a way to estimate a patient's due date. Okay. So you're taking the first day of the last menstrual period, and then you subtract 3 calendar months, add 7 days to that, and that is going to be their due date. This is typically based on a 28-day cycle. Okay, so your patients who come to you who have had fertility treatment or have PCOS and they don't have a definitive last menstrual period, those patients, you're not going to be using Naegele's rule. You're going to be going off of ultrasound. Okay, usually around 8 to 10-ish weeks of pregnancy, a woman will get a dating ultrasound, which will confirm their last menstrual period and compare it to how the fetus is measuring, and give a more definitive due date. But if you're triaging a patient over the phone and they tell you, oh, the first day of my last menstrual period was this, then you can use Naegele's rule to calculate that. So definitely know this. You guys are going to want to know how to calculate a due date based on with this rule. Okay. But always remember that the most accurate way to get a due date is confirmed on ultrasound.
Professor Young,
Yeah.
I sent you a message in your chat. Can you peek at it real quick?
Yeah.
Sorry to interrupt.
Oops.
Sorry, I'm not trying to take up too much time.
Oh no, you're fine. Lorena, I accidentally just sent you a message, but that was for Professor McBride.
Actually, I'm wrong. So continue. I'm sorry.
Oh yeah, no
I
worries.
was mistaken.
Alrighty. So, kind of moving on to psychosocial adaptations. So, with pregnancy, you're not only having a mom who's coming in with having a lot of like body changes and things happening, hormone fluctuations, all these things. There can also be a lot of psychosocial things that are happening outside of the pregnancy that are impacting the way this woman may be feeling about the pregnancy or and how she's adapting to it, right? So financial concerns, that's a huge part. That is a huge part of pregnancy. So if a woman has this high stress levels because she's worried about her finances, that can like high stress can be pretty hard on a mother's body, especially during the first weeks or trimester of pregnancy. Um, any type of adaptations to the pregnancy, moms adapting to it, partners adapting to it, siblings of this future child adapting to the pregnancy can be different depending on family dynamic and overall how the pregnancy is being received. So I personally don't have any children yet, but I'm sure like having another child and like having to tell them that you're having another baby is both an exciting and also kind of intimidating and terrifying thing because introducing another life to your family is a big thing. Um, in the first trimester, moms and family dynamics can also feel different ways uh, during each trimester. So in this first trimester, you might see a mom who has conflicting feelings. Um, they are going to be excited. They're also going to be a little bit nervous, especially if you have a mom who comes in and she's had a history of multiple miscarriages, right? That is going to impact the way somebody feels about a pregnancy, okay? Because they're going to be excited, but they're also going to be like concerned, nervous. Is everything moving right the correct way? A little bit of like denial of like is this pregnancy going to make it to term, and that's really difficult for an individual to have to go through, and as their nurses we need to be understanding of that and be able to comfort them and be there for them. In the second trimester, once you get past that 12-13 week period, motherhood feels a little bit closer, feels a little bit more real, and then moms begin to kind of like get their have their mind wrap around the idea of like, yes, okay, I'm going to be having this baby. This is going to be a new addition to my life and to our family, and it's going to be awesome. And start to kind of adapt to this and get used to this. And then, let's see. And then they're adjusting for the arrival of the baby. They're going to be planning, getting things together, making different adjustments to their work schedules or home schedules as needed. Third trimester, this is pregnancy discomforts kind of increase a little bit again. So your first trimester, you're having the nausea and vomiting, you're having the hormone fluctuations, all those things we kind of talked about. The third trimester, um, the uterus and fungus have grown. Any type of position is going to be very uncomfortable for most moms. They may have those symptoms that are coming back up again, the nausea, the vomiting, constipation, diarrhea, anything like that. So they're getting a little bit more uncomfortable again. They also will have some mood swings because of hormone fluctuations. This happens all throughout pregnancy. But third trimester, as they're getting closer to the end, that can be a little bit more prevalent as well. While it's important to know how these things are impacting mom, it's also really important to take into consideration the fact that the partner is also going to be playing a major role in this pregnancy and have a lot of different feelings about it as well. So there's different phases that we're going to kind of go through each one. Um, the announcement phase. This is accepting the biological fact of the pregnancy. So a thing to note is that this can happen a lot later for a partner than it will for a mom, right? So a mom comes to dad and is like, hey, I'm pregnant. She's like 4 weeks pregnant. She found out as early as you can. A dad isn't really going to have his head wrapped around that because to him, nothing is really different, right? So mom is having all these different symptoms, these different things happening. Dad is kind of there supporting her, hopefully, in the way that she needs to be supported, being there for her in the way she needs him to be there or them to be there. But ultimately, they're not going to notice anything really that different. Moratorium phase is accepting the reality of pregnancy, becoming introspective, and imagining raising a child or how to raise the child. So these are when the partner is going to be asking, like, what are the things that we want to teach this child? Do we want to send them to public school? Kind of going over the more like fine details of life, the things that they're going to want to be considering moving past after delivery of the infant, after birth, and into the first years, weeks of life. So, and then the focus phase, that's kind of talking with the partner and the role he's to play in labor and for infant's arrival, or them, or whoever the support person is for the baby's arrival. So, childbirth education classes. This is something that every pregnant woman should have access to through their office, their gynecologist, their OBGYN. And it should be something that they should have been encouraged to bring their partner to with them. So, support in labor is one of the biggest components. So, not only educating mom, educating partner on here are the things that you can be doing to support her during her labor, during her delivery, after the baby is here, and giving them this education so that they can be ready for the delivery of the infant. Okay. So why don't we go ahead? It's about 3:31 Eastern time, so that's noon, 12:30 Pacific, and 2:30 Central. Why don't we have 15 minutes break here ish? So come back quarter till, and we'll pick up where we left off. Okay.
Thank you.
All right, everybody, welcome back. Let's go ahead and get right back into the PowerPoint. So we end at 4:41, so we've got a little under an hour left of class. So let's get through the rest of this PowerPoint, and then we'll review what is due for next week and go over a little bit of that stuff, okay? So let's see where we left off. Alrighty, so we're gonna go and start getting into prenatal visits and the kind of education that you're going to want to go over with your patient, okay? So the initial prenatal visit consists of your prenatal interview, some routine testing, and then a physical exam. So your prenatal interview, you're going to be focusing with the patient on the current pregnancy, how they're doing, how they're feeling, their due date, last menstrual period if they have one that's reliable, any reproductive and sexual history health, if they have a history of STDs, STIs, if they do have a history of HSV, this is one that providers will make sure that a woman is taking Valtrex or acyclovir or any other type of antiviral medication, because if a woman has a herpes outbreak during pregnancy or during closer to when the baby is delivered, she cannot deliver vaginally if that she has an active lesion. Okay, so we want to make sure that that's being adequately treated. So those are some things that we're going to be asking the mom in this initial prenatal visit. Underlying health history and underlying medical conditions, any medications that they're taking. Are they taking a prenatal vitamin? What other meds are they taking typically? Big ones that we really want to make sure we are asking about are any type of SSRIs, because certain SSRIs can be unsafe in pregnancy. So if they're wanting to, if they are currently on an anti-anxiety, antidepressant, we want to see what's the dose is and what medication they're taking, because some of these SSRIs can cause withdrawal in infants when they're delivered. Nutritional history, what their food intake is looking like, water intake, family history. If parents have a history of any type of genetic abnormalities or chromosomal inherited conditions, we do want to know if there's any siblings that have been born with Down syndrome, any close relatives or family members that have any of like those trisomy 18, 21s, anything like that. What they do for work. If they're a nurse and they're on their feet for long 12-hour shifts, you really want to be encouraging those breaks and oral hydration to the best of their ability. Asking like if they're on their feet a lot is a really important question during these intakes. Mental health screening, making sure that they feel safe at home, any underlying anxiety, depression, that kind of stuff can increase in pregnancy. So if a woman has a history of anxiety and depression, the odds of her having a hard time during especially the first trimester of pregnancy is increased. So we want to be checking in on these moms, making sure they're feeling safe at home, making sure they're okay. And then kind of going back to the things that we talked or were presented on in week 1, any history of intimate partner violence or abuse. These are things that we want to be continually asking the moms whenever they are coming in for visits, routine exams, when they're coming in to deliver the baby, making sure they're feeling safe, that they have a safe place for them, for themselves and for the infant. Routine tests. There's a really good table that kind of goes through each one on page 189. I'm hoping it's the same for you guys. That kind of goes through each test that we do, what week of pregnancy they're usually done at, and what they entail and what they're testing for. At every single prenatal visit, they're going to be getting a urine sample from mom. This is mostly for a UA, just to make sure the mom doesn't have any urinary tract infections. Because like we mentioned earlier, moms are more prone to UTIs during pregnancy. So doing these routine UAs is going to just protect mom, make sure she's doing okay, protect baby, and ensure that the pregnancy is going well. Cervical swabs will be performed to test for any type of bacteria, could be like BV if they're testing for any bacterial vaginosis. Also for like chlamydia, gonorrhea, that is a swab, a cervical swab that that OBGYNs will do in one of the first like prenatal visits for moms, just because any STDs, STIs have an increased risk of miscarriage or developmental abnormalities with the baby. So we want to make sure we're getting those tested really early on. Physical exam, we're going to be doing a head to toe. You're getting your patient's vital signs. We're doing blood pressures routinely, temperature, all that good stuff. Making sure the mom like physically is like looking well. And then occasionally they'll do a pelvic exam just to make sure like anatomy wise that the cervix is looking okay, that it's not red or inflamed, showing any signs of infection. I'm not sure, I don't know if they are doing this with every prenatal, initial prenatal appointment, but they're just making sure and wanting to ensure that there's no underlying infections that will cause any issue in the pregnancy. Education during pregnancy is huge, especially for your first time moms. This is something that they've never gone through before. This is a really big change in life, and it's very important that they're getting all the education that they need to ensure that their health and the baby's health are sustained throughout. So you're going over with them their expected maternal and fetal changes, those things that we mentioned, the physiological changes that they're going to be experiencing. You want to tell them about that because they don't want to be taken by surprise by anything, you know. Encouraging them too, like, hey, if you notice anything like this is when you should be calling into the office, right? Giving them those guidelines, kind of any vaginal bleeding, any cramp and severe cramping in your front or in your sides or in your flank. Those are things that we want to know about. Adequate nutrition, foods to avoid, foods to increase. So especially if like a mom first is not wanting to take prenatal vitamins, we've been seeing a higher instance of moms not wanting to take additional medications during pregnancy, and who are wanting to opt out of like medications for baby. It's personal choice, you know. But we also then want to be encouraging them. Okay, if you're not getting a prenatal vitamin, you want to be increasing your foods that are high in folate, folic acid, to prevent neural tube defects or abnormalities. Okay. Going over posture and body mechanics, rest and relaxation, encouraging that, hey, it's okay if you rest a little bit more, especially in this first trimester. You're going to be exhausted, a little bit more fatigued. That's all right. If they do have plans on travel, the big one is where are they traveling to? So if they're traveling to a country where they need to get specific vaccinations, that might not be an option for them in pregnancy. So kind of going over that with them, right? So if they're like wanting to do a mission to Haiti or to Southern Africa, you know, and they have to get specific vaccines to travel to these places, that might not be something they can receive. So being a little bit more realistic with them. When travel should stop. So I believe it's after 32 weeks, they don't want you flying. Really, in your third trimester, traveling outside of the radius of where you're going to be delivering, your OBGYN is going to be giving them a little bit more education about that. Sexual health and sexuality, safe sex, educating them on if they do have a new sexual partner, to keep the OBGYN and the office and notified if that is happening, because we want to be monitoring them for any STDs, STIs, encouraging safe sex, especially during pregnancy. Childbirth classes and expectations for labor and delivery. This is huge. Making sure moms have adequate resources to kind of give them, all right, here's your expectations. This is what this is going to look like when you come to the hospital. Here's where you enter, all those kind of things. And then birth preferences. This is really big because in the hospital at your bedside, you're admitting your patient and you might not always have the time to ask them, do you have a birth plan? But talking to moms about, okay, here's what an established birth plan can look like. We have this option, this option. If you're wanting to go natural, we can do this for you. In the room, you can have your lights dimmed. We can have aromatherapy. We can sometimes get moms in the tub for delivery. My hospital does tub births, which is an option if a mom has a very low risk, no complication pregnancy. I've had like 6 or so tub births this month. It's been really popular. So if that's an option for moms, we want to make sure we're giving them to them, because this again is uncharted territory for most women. They don't know what they're getting into. So we want to make sure we're encouraging them and showing them. If there's any substance use, encouraging stopping, giving them resources on stopping. So like smoking, cigarette use, harder drug use, anything like that. We want to be encouraging stopping. We also want to be giving them resources to quitting, or consulting the appropriate individuals that we need to, as far as like if there is substance abuse or history of substance abuse in with a family or in a home. Immunizations, what is safe for a mom to have, what is not safe for a mom to have. Right now is flu season. Moms can get the flu shot when they're pregnant, kind of going over those things with them. A big one is the Rh immune globulin. This is a test performed and determine maternal blood type. So an Rh negative mom carrying an Rh negative fetus can develop antibodies against the fetus. So they're going to need to receive RhoGAM during pregnancy. This will prevent miscarriages and other issues. So knowing a mom's blood type, if they're O or a negative Rh, they're going to want to receive RhoGAM during the pregnancy. That is one of the things that they will test. One of the first things they will look at if a mom has had recurrent miscarriages. What is her blood type? Is this an Rh factor issue? Does she need to be receiving RhoGAM earlier in the pregnancy? Should she be receiving RhoGAM at all? And then whenever they do receive the RhoGAM, you want to make sure that it's adequately charted, because oftentimes moms will need to receive RhoGAM as well after the baby is delivered, and they're going to want to know when that first dose was received during pregnancy. Personal hygiene is a big one. Kegels and strengthening of the pelvic floor muscles. Encouraging moms too, like these are some really good stretches that you can do before pregnancy to kind of prepare your body for birth. These are exercises and activities you can still do. Activity restriction in general, right? That is kind of something that is per the OBGYN's recommendation. But if you have a mom who comes in and she's in her first trimester and she's used to running 8 miles a day, that's her baseline. As long as she's not having cramping or bleeding right now, the recommendation for most OBGYNs is continue to do what you're comfortable and what you have been doing, okay? No increasing, no adding in things that you've never done before. But if you're used to doing these things, keep on doing them. Oral health is a big one. They can still go to the dentist and get cleanings. We just encourage them, if the dentist wants to do x-rays, either to hold off on x-rays or to make sure they have the appropriate like lead shield on, and tell their dentists like that they're pregnant. Comfortable clothing, educating them about their job. If there's any lifting restrictions that they're under for some reason, like if they're having some early spotting and the OBGYN doesn't want them lifting more than 10 pounds or something like that, making sure that they're aware of that if their job doesn't require this. And then any like potential complications to educate a patient on and like kind of talk them through. Page 200 has that table that kind of goes through most of those things for you guys. All right, so moving on to maternal and fetal nutrition. Dietary considerations. So your diet during pregnancy plays a huge role in fetal development and overall fetal health. So weight gain in pregnancy. This is something that the office will go over with the patient, and it is very dependent on a mom's pre-pregnancy BMI and weight. So typically we're looking at a woman gaining about 25 to 30 pounds per pregnancy. A little bit less if the BMI is over 30. Okay, so if a woman's BMI is over 30 pre-pregnancy, they don't need to, or we don't really expect them to gain as much weight during their pregnancy. Nutrition needs for pregnancy begin even before a woman gets pregnant. So sometimes if a mom says like, or a woman comes in the office and says she's trying to conceive, an OBGYN will encourage her to start a prenatal vitamin even before she is pregnant. That will just increase folic acid and folate to prepare her body to for pregnancy and for growing a fetus. You're also going to want to talk to them about their nutrient needs throughout pregnancy, their calorie intake, and increasing these things during pregnancy. Like a woman's calorie intake does need to be increased, and food intake can be increased. Like healthy food intake should be increased. Considerations for an iron supplementation, that just means like if a woman is already kind of hovering between the line of she's anemic or not, a provider may want her to have a prenatal vitamin that includes iron as well, or increase her iron supplementation outside of the prenatal if that's what they think is necessary. If you have a patient who is vegan or vegetarian, the nutrition guidelines are going to be altered just a little bit because we still want them to be getting the adequate amounts of nutrition from each of the food groups, but you got to get a little bit creative if they have some like dietary restrictions or glucose intolerance, anything like that. And there are a lot of really good pamphlets and resources that the offices will give out to patients that kind of goes through like nutritional guidelines and all of that stuff. Foods, you can also tell them about foods that are going to reduce constipation and bloating or heartburn. So like telling them to avoid, okay, maybe don't dump hot sauce on every single one of your meals in this first trimester. You might be a little bit more uncomfortable. If they're nauseous and vomiting, really at that point, you're telling them to intake whatever they're able to and whatever they're able to really keep down. Like usually nausea and vomiting will decrease after that first trimester, but it doesn't always. So making sure they have a select group of foods that they can tolerate, that will continue, that they can continue to eat during the pregnancy. So sometimes pregnant women will show signs of having pica, which is whenever you're eating things that are not normally consumed, and it's because your body is compensating for something that it's lacking. So if a woman says that she's eating like ice chips like nobody's business, okay, that can sometimes be a sign that they are low in iron and that they may need to increase their iron intake. So if they're saying they're craving like really, really weird things, like not food related things, they probably should have labs drawn to check and make sure that their electrolytes and their vitamins and all those levels are normal. Why do you think we would need to have an increased consideration for adolescent pregnancy dietary intake? Why would we be worried about our adolescent population?
Don't they typically have a higher calorie intake?
We want them to increase their calorie intake. Typically with adolescents, it's lower. Sometimes there's a financial component in there as well. So like if an adolescent who's pregnant comes to you and they don't have the best support, and they have a lot of financial concerns, they're not going to be able to have as well-rounded of a dietary like sustenance for themselves, or as many resources available to them. And then diabetics too. That is something that is a little bit more complicated because you're not only working with the pregnancy, you're also working with their increase of insulin, their insulin demands, making sure their blood sugar remains stable. So a lot of education is going to be gone over with them. You also should tell them and encourage them to reach out to their endocrinologist, whoever is managing their diabetes, to kind of go over with them too, like the expectations and the caloric demand of pregnancy. So kind of bouncing off of dietary increases and restrictions, a huge one that we want to talk about are neural tube defects. So neural tube defects are most likely caused and related to the amount of folate and vitamin B9 that a mother ingests or takes in during pregnancy. So it's important that a mom will increase her intake of folate to reduce instances of neural tube defects. So this is also why an OBGYN will sometimes encourage a mom to start a prenatal vitamin when trying to conceive. So your prenatal vitamins are building up in your system and they like just continue to add and add to your overall levels. So taking a prenatal vitamin before trying to conceive is giving you a really good base for adequate fetal development and fetal growth. So risk factors for neural tube defects, if there's a family history, that is a big one. Um, Folic acid deficiency in a mom. Pregestational diabetes can sometimes cause that just because the mom's body isn't processing the vitamins the same way that a non-diabetic would. And then teratogen exposure, so alcohol use, substance abuse, cigarette smoke exposure, those kind of things can increase the risk for neural tube defects. This happens, it's a result from failure and closure of the neural tube. So these are like spina bifida and anencephaly are neural tube defects. I have a picture over here of spina bifida where you have that opening and then the spinal cord and spinal fluid is coming out through it. Sometimes too, like you won't on an assessment, a baby can have like a little dimple. Like once I had an infant who just had a dimple and had like some hairs growing out of it. That is something still you want to bring to the attention of the newborn provider because they're going to want to follow that and manage that closely, right? Even if it's not a full open, like you can clearly see that this is spinal fluid and spinal content, that is still something that you're going to want to make note of. And because the provider is going to track that throughout the infant's life and make sure that it goes away or resolves itself on its own. So assessment of the high risk pregnancy. So risk factors that can contribute to a high risk pregnancy. So biophysical factors would be like your genetic considerations, nutritional status, medical and obstetric disorders. Psychosocial are those other outlying external factors, so like you're smoking, if the mom is smoking, how much caffeine they're intaking. Right now, they're saying on a little under 200 milligrams of caffeine a day is safe in pregnancy. That's about 1 to 2 8-ounce cups of coffee if a woman is asking you. So if she's used to working night shift on the floor and she's drinking Alani's every 3 hours, you gotta be like, all right, we need to cut this down by a lot. So that's something because caffeine, high amounts of caffeine use has been shown to increase a mom's chance of miscarriage. Alcohol use, drugs, psychological status, socio-demographic risk factors are like low income moms, any lack of or no prenatal care, age, how many children they already have, and then like your social detriments of health. Do they have access to health care? I'm going to reference the Amish a lot because I've worked really closely with them. But like some of the Amish patients that I took care of, they never had any prenatal care because they don't have automobiles or they don't have a means of getting to and from the office and to their appointments. So that is a huge thing that you see a lot of the time is no prenatal care. And they'll just come through the door and they're like, I'm ready to have my baby. And they've never been seen in the office once. So you'll see that in the hospital, not just with the Amish population, with a lot of different populations of patients will sometimes not have prenatal care. Environmental factors would be like infections, any exposure to radiation, chemicals, stress is a big one, and then your diet. So a biophysical assessment that you're going to want to do on high risk patients, really any patient, is you're going to be talking to them a lot about fetal movement and kick counts. Okay, so this isn't going to happen until a little bit later in the pregnancy. This is not anything you're going to be going over with a patient in their initial prenatal exam or education because it's going to be a lot of information that they're getting. So a patient should be feeling about 10 fetal movements in a 2-hour period. There should be encouraged to do this at the same time every day. And then, so say a mom calls in to you, you're a nurse, you're working on the labor and delivery floor, and she says, I haven't felt my baby move in 3 hours. What would you encourage her to do?
Drink something cold.
Mm-hmm. Yeah.
Maybe go for a walk or something.
Yeah, those are good. Yeah, what usually we want to encourage is fluid. So drink a whole water bottle. You can encourage them to do some activity if they haven't been moving in that 3 hour period. If they've been up and moving and really active, encourage them to lay on their left side, right? Because we say the left side increases the blood flow and the oxygen flow into the placenta, and that will sometimes get babies to wake up and move around a little bit more. Um, and I usually only give them I usually tell them 20 to 30 minutes of doing that. If after like that 30-minute period, they're still not feeling any movement, they need to come into the hospital to be evaluated so that the baby can be put on the monitor and you can make sure that everything is looking okay. Um, Fetal movement and these kick counts, if a patient is telling you that their baby isn't moving, um, it is considered an emergency. So you don't want them to be trying these things at home for like a very extended amount of time. You want them to come into the hospital relatively quickly if these interventions aren't helping. So our go-to testing for visualization of an infant is an ultrasound. Why would we like why do we use this compared to other tests? Like why is the ultrasound usually the golden test in pregnancy?
You're able to assess fetal heart activity, and it's more like absolute.
Yes.
You get to measure the length of the baby to see if it's growing at the right rate as it's supposed to be.
Yes, you can do that.
It's less invasive.
Yes, definitely. So that's definitely the reason why we prefer ultrasounds. Like ultrasounds are not invasive at all. You're not really exposing your infant to any risk compared to like an amniocentesis or like umbilical cord venous sampling, anything like that, or chronic relay sampling, whatever is those things are a little bit more invasive. They pose a higher risk to the infant. They pose a higher risk to the mom. The ultrasound is a better form of testing because you're able to assess for all of these things without it being invasive or being a major risk to the baby. Um, Ultrasounds, like I have listed here, are great because you can see fetal heart activity. You can get an appropriate estimation of gestational age. You're looking at the fetal growth, fetal anatomy. A lot of the stuff that will be diagnosed with other tests most of the time, you can see or note them on ultrasound as well. So, um, and then you also can see the placenta location with an ultrasound most of the time. Okay, so if we're worried about a placenta previa, we're going to want to, at their 20-week anatomy ultrasound, that is going to be more definitive than just like in the office, like on a regular scan. But whenever they go to MFM for that anatomy ultrasound, uh, it's going to be able to tell the placenta location, which is huge because if the patient has a placenta previa, we're looking at a whole different type of management for their pregnancy. Okay. So ultrasounds are awesome. That's why it's the go-to for OBs. Alrighty. So we also have a couple other tests that we can use for the fetal well-being assessments. So one is the Doppler blood flow analysis. This is the study of the blood flow in the mom, fetus, and the placenta, and it's also an ultrasound. Um, this can be a good indicator of how the fetus is doing, their adaptation and reserve. And this also will look for severe restriction of the umbilical cord. So it's making sure that there's like really good blood flow, basically, between mom, umbilical cord, and the fetus. And if there's any like type of abnormalities noted, further testing can be indicated from that. But this test is a really good indicator of how the reserves are doing, how baby is looking. Um, an AFI, we want to look for the amniotic fluid index. We're looking at the amniotic fluid volume, the amount of amniotic fluid that they have, which, as we were talking about in previous slides, the amount of amniotic fluid is really important because it provides the nourishment and the protection for the baby when they're in utero. So we're looking for abnormalities in the amount of amniotic fluid, which is your oligo and your poly. So your AFI uses a Doppler, and it gets the estimate of amount of the amniotic fluid totaled in all four pockets. So it kind of splits the and the amniotic fluid sac into four little sections, and it gets the total that's amount in each of the four pockets, and it gives you the amniotic fluid index. Okay, so over here I have the kind of the parameters for the amniotic fluid index. So anything under 5 centimeters can be diagnosed as oligo, and anything greater than 25 is considered poly. An amniotic fluid index is something that they measure in a biophysical profile, a BPP. Okay. So all of these things are ultrasounds, non-invasive. A BPP, which is the next one down here, there's a really good table on page 231 that you guys should reference whenever we're talking about BPPs because it goes through every single category that is tested on a biophysical profile. But it's basically a detailed assessment of physical and physiologic characteristics of the fetus. So it includes tests of the amniotic fluid volume, fetal breath movements, fetal movements, and then fetal tone. So these things will give you a score out of 10. So a BPP of 8 or higher with a normal amniotic fluid volume would be considered normal. Okay. Anything under 8 on a BPP, that mom is going to come to labor and delivery and she's going to be put on the monitor. We're going to be looking at the baby and potentially doing other interventions or other tests to kind of see what's going on, right? So, like if a mom comes in who's complaining of like decreased fetal movement, we're monitoring her overnight. The strip looks okay. The provider might order another ultrasound or a BPP to be done in the morning to kind of give us a better picture too of what's going on. Why is the baby not moving, or what's going on with this infant? So these next couple tests we're going to go over are more invasive. Okay, they're biochemical assessments. So an amniocentesis performed after 15 weeks gestation, and it's a procedure that collect amniotic fluid for testing. This can be testing for any infections, genetic disorders. Why would we not want this to be completed earlier than 15 weeks?
Risk of miscarriage?
Yes, definitely. Amniocentesis, this is an invasive test, right? So, and also like your amniotic fluid sac, which we're sampling from, isn't like before 15 weeks, like that's a very, very small portion of the pregnancy. So we want to make sure that we're able to adequately visualize where we're going, where we're sampling from. If you're just going in blind, like you're really dangerous. So it also, like you said, poses a high risk of pregnancy loss, some amniotic fluid leaking, and also could result in like a club foot or a formation abnormality in the fetus if you're doing these things too early or if it could be unsafe. These we're going to just go through the risks because we're running a little low on time. But as far as risks with this procedure from a maternal standpoint, okay, like I said, we have potentially leakage of amniotic fluid. A mom could hemorrhage from this. She could get an infection, right? Because if you look at this graph, you're literally injecting a little needle in here to aspirate and collect some of this amniotic fluid, right? That anytime you're introducing something foreign into a body, you're posing a risk for infection. It could send them into labor, preterm labor, and also could result in a placental abruption, which are all huge things. As far as the fetus, you're looking at potential death, hemorrhage, infection, or a direct injury from the needle while they're performing the testing. Okay. So let's see here. So, like I kind of mentioned when we were talking about the genetics and stuff, like at the beginning of the PowerPoint, genetic carrier screening can be performed anytime after 10 weeks of gestation. This is whenever mom's blood is sampled to see if she's a carrier for anything abnormal or if the baby has a higher chance of having any type of abnormalities. Um, multiple marker screens. So these are specific screens that they're looking for to tell us if there's a high chance of the infant having something abnormal. So maternal blood is what we're testing for. Alpha fetoprotein is the one that I want you guys to remember because if it is low, um, that baby has a high chance of having Down syndrome. If the AFP is high, the baby has an increased chance of having a neural tube defect. So the alpha fetoprotein is something that providers are looking at pretty closely because it can give us a good indication of these two abnormalities with the fetus. Okay, so this is definitely something you're going to want to remember. So chronic villus sampling is performed between 10 and 13 weeks, and this is removal of a small tissue from the placenta. I have a picture over here. In the next slide or so, I have a video that you guys can watch that shows how chronic venous villus sampling is performed, and I think I also have one on amniocentesis. I believe those are the two that I included. And then the other one I wanted to touch on is the percutaneous umbilical blood sampling. This can kind of gives us an idea about fetal anemia or any type of thrombocytopenia. It also will kind of be able to test the blood for any infections or any like type of like transfusions or anything that's weird that's happening within placental and maternal fetal blood flow. Okay. Yeah, okay. So here are the two videos. We're not going to watch them right now just because we have a couple more slides to get through and I want to make sure we can give them the adequate time. So on your own, go ahead and take a peek at these two videos and it'll go through. They're really short. I think they're less than 5 minutes each and it shows you the procedure and how they're done. So slide kind of goes through a little bit more in detail for that carrier screening and the blood sampling that they're getting from mom. So the big one is the alpha fetoprotein, like we talked about, that can test for the Down syndrome and the neural tube defect. But there's also the let me see, Coombs test. So this is what is screening for that Rh isoimmunization. So this is something that they're doing to see like mom's Rh factor, fetal Rh factor, if there is a need for ROGAM. And then also like an amniocentesis can be performed to detect any bilirubin that's present in the amniotic fluid. And this will figure out the severity of fetal hemolytic anemia. So like if a baby is jaundice, okay, and this isn't, you're not going to be able to tell that in utero. At delivery, we're seeing if the baby has any type of like fetal hemolytic anemia. But their main thing that they're going to present with is that jaundice, the yellowing of their skin, their eyes. Excuse me. And then we also have cell-free DNA screening. Again, this is a maternal blood sample, and it tests for extra or missing chromosomes in the fetus, and it will tell you the sex of the infant, Rh status, any single gene disorders transmitted from parents. So in that 10-week carrier screening, moms can opt to know the gender of the fetus with that blood draw as well. So, but like I said earlier, some moms won't do these screenings because insurance isn't covering them all the time just yet. It's not a commonplace thing that insurance is covering. So it's like $400 out of pocket. And if finances are a thing that is a stressor in a woman's life, they probably are not going to be spending that money to get this testing done. Alrighty. So this slide is going over a little bit more in detail about that ABO compatibility and the RH factor, which is derived from mom's cord blood. So a mom's RH status, and it's going to determine the RH incompatibility at birth. This occurs if mom is RH negative and baby is RH positive. So mom's body is developing those antibodies against the baby, which can lead to increased chance of miscarriages and other complications during the pregnancy. It requires RhoGAM in pregnancy and after delivery to prevent the development of antibodies to future pregnancies, which is those miscarriages and the fetal hemolysis in the next baby. Your Coombs test determines ABO compatibility at birth, and this affects the current pregnancy. An indirect Coombs test detects antibodies in serum, which is the mom's, and then a direct Coombs will detect the antibodies on red blood cells in the baby. So whenever you're working in a hospital, each hospital has a different policy as far as like cord blood collection. Some hospitals send cord blood on every single mom, which is not entirely necessary, right? If mom's B positive, you don't, or A positive, or B positive, whatever, has a positive RH, we're not worried about this incompatibility between her and fetus, right? We're looking mostly at the cord blood of moms who are RH negative. Okay, that's the big one. O blood types and RH negatives. So those are the moms that you're getting the cord blood and you're testing for to make sure that baby's, if she needs RhoGAM, what baby's blood type is, and all of that good stuff. Okay. Alrighty. So an antepartum assessment that we rely on pretty heavily is electronic fetal monitoring. So an electronic fetal monitor, we have a little bit of a graph over here. You've got your transducer, your TOCO up here that monitors any uterine contractility and uterine contractions. And then your ultrasound down here, which is determining and listening to fetal heart rate. Okay. There are a couple tests that we can do to see how the baby is doing in utero just based on electronic fetal monitoring. This is not an ultrasound. It's just listening to the baby and seeing the baby's heart rate on the screen and the patterns, which we're going to go over in this class later. I don't really know which week we're going to be going over it. I haven't looked that far ahead yet, but we'll definitely be going in detail on fetal heart rate tracings and strips. Okay. A non-stress test is a very common thing that we do in the hospital, almost like all the time. This is analyzing a fetal strip over a 10 to 15 minute period. So a mom comes in and says her baby's not moving. We're going to do an NST. Usually you have mom lay on the left side. You position the ultrasound and the TOCO to make sure that they're picking up the baby's heart rate, as well as any uterine contractions that she may or may not be having. You're assessing for variability, presence of accelerations, and also sometimes you can detect fetal movement on a tracing. It is not as reliable as mom being able to feel fetal movement. Okay. An NST is graded as reactive or non-reactive, and there's certain criteria that an NST has to meet. So a certain number of accelerations in a 10 to 15 minute period. There should not be any decelerations in that 10 to 15 minute period. You want that baby's heart rate to have really good variability, which this is going to make a lot more sense whenever we do go over fetal tracings in class, whenever we're looking at those, because right now those terms might not mean very much to you. But ultimately, you want an NST to be reactive. That is a really good indicator that all is well with fetus, that baby is looking good, that mom can rest assured that things are fine. A contraction stress test is not as common because it's more expensive. It takes a little bit longer, and you're actively like doing things to potentially stress your baby out. So I've been a labor and delivery nurse for almost 6 or 7 years now, and I've never done a contraction stress test. Granted, I don't work at a big hospital facility, so that might be more common on like a level, like a trauma facility or a bigger hospital, but I've never really done one of these. So they're also called or referred to as an oxytocin challenge test. This identifies stable at rest infants versus like if the baby's going to be compromised with stress. Okay. So you're basically administering Pitocin while monitoring the infant after you obtain a 20-minute baseline. So you're seeing how a baby is doing when the mom is having contractions, basically. Okay. And like I said, this is not as common because it's expensive, it's a little bit more time consuming, and you're actively like putting the baby under more stress. A non-invasive procedure that a lot of the times providers will do in the office or at the bedside, like say they're going to be like starting an induction or whatever, are Leopold maneuvers. This is performed using abdominal palpation. You can see the pictures down below that show you. Um, these this answers the following questions: which fetal part is in the uterine fundus? Where is the baby's back? And then what is the presenting part? Okay. The one thing I'm going to add about this, if you're a labor and delivery nurse and there's a mom that's coming in for a scheduled induction and you don't have a documented ultrasound saying that your baby's head is down, a provider needs to have an ultrasound showing you that the baby's head is down. Leopold maneuvers are effective to a certain point, but if you're going to be starting an induction, you want to definitely verify and visualize that baby's head is down on an ultrasound. Okay. Basically, this just gives a provider an idea of where the baby is at, how the baby is lying, if the position is favorable for a vaginal delivery, um, or if the baby is turned, right? So, like a mom came in the other day for an induction, and her baby had moved and was lying completely transverse across her abdomen. So the head was like on one side of her belly, the butt was on the other side of her belly, so it's laying like horizontal in her belly. So, and you can kind of almost see that when a baby moves, like the mom's belly looks different, it doesn't look very rounded or natural. It's got a little bit like of a lumpy, deformed shape to it. But you can like we performed the Leopolds at first. We got an ultrasound, obviously, but we performed the Leopolds first, and you could feel that head and that butt the way it was. So she ended up having a C-section, unfortunately. But Leopolds can be effective in determining the position. So just something to note. You don't need to know, I don't think, each of the names of these procedures, but they have like specific names associated with them. Okay. But I believe that is it. So let me stop sharing this, and we're going to go over what is due coming up here. So this week you have, like I said, that discussion number 1 in your sim chart, the intimate partner violence. Oh, Professor McBride, I did have a question. One of the students had asked if that first attempt that they have on sim chart is the final attempt.
It is.
Okay. So I just wanted to clarify that with someone else before I gave you guys an answer. So yes, so your first sim chart attempt is going to be your only sim chart attempt. So, and then so week 3, you'll have the infection sim chart due, and your NCLEX number 1 will be due. So those will be due on Sunday night. Okay.
I
So
have a quick question. So for the Saunders questions, I don't know what your grading is like, because some professors are different. So, like, say we did our 50 questions and we got like a 45 out of 50, do we still get 50 points, or do you give us the points that we got on it?
that is a really good question because I've actually never graded one of these before. So
Some professors like do it differently because in my other classes before like med surg, like we have to do 25. And if we get at least 20 out of 25 correct, then she gives us all 25 points. But in pharmacology, my teacher gave you the point that you got. So like if I got a 10 out of 25, she would give me a 10.
oh, okay. I see what you're
I
saying.
didn't know how you did it.
So I'll probably be working with Professor McBride on that, but what do you usually do?
So for the NCLEX questions, you can do them as many times as you want to get the score you want. You need to do all 50 questions, okay? And you need to follow the directions really closely in that assignment. So we have our first one next week in week 3 because we do it the week before each exam. You'll do all 50 questions. You will only want to select the categories that it tells you to select, and new questions only. and then you do it. And if you don't get a score you like, do it again if you want to. Okay. You need to then download and save it as a PDF, so not a screenshot. And you need to name your file with the instructions it tells you in the instructions of the module. And your score will be point for point what you earn.
Thank you.
The other place you can look for some of that information is if you go back into the orientation PowerPoint, it'll show you how a lot of the things are graded, how to submit your assignments, and things like that. So you can also reference that as well.
Thank you.
Is there a minimum out of the 50 that you have to get?
Nope. You guys choose. If you're having a rough week and you're like, I just gotta get this done and turn it in, and you score like 22 out of 50 and you're like, I'm fine with that. Okay. But we do encourage you, because this is one of those places where you control what those scores are. And so I do encourage you. We all encourage you guys to redo them if you have the time. The other thing that's really a good resource for you is to go into that separately from when you're doing it as an assignment. And instead of selecting exams, select study mode, because then you can click on the rationales and you can take your time and look at, well, I missed this one. What was the correct answer? Why was it the best choice? And things like that. So it's also helpful in that way.
So real quick too, I just had a question about the discussion posts. So on the discussion posts, we have the prompt like posted on the top here. Um, and yes, you should have the responses posted on different days. Like you should do your initial one and then respond to another person like on a separate day. Don't do them both on this at the same time per like what the um, prompt is saying in Canvas. Your initial discussion post needs to be posted by midnight on Wednesday, and then your response to your peers just needs to be submitted before Sunday night. Okay. As far as like a rubric or the guidelines or anything like that goes, I think, do they have access to a rubric?
Yep. And so there are definitely some guidelines to earn your best score on your discussion posts as well. So following the rubric is a good idea. Um, you're going to need a scholarly source on your first post, your initial post, a scholarly resource that is less than 5 years old, that you use an APA formatted citation for. You need to include an in-text citation. Let me think what else. Scholarly source, less than 5 years. Then what Professor Young said about the different days. Um, and I think that's it. You don't need a scholarly source for your responses. Your responses are a good time to really, you need to like have a nice formulated response, not like, Jasmine, I agree with you, good job. But I saw this at clinical this week, or this happened in my pregnancy, and this and this and this, or whatever. And so you're like moving the discussion forward and you're saying, yes, I agree with you. Or maybe you don't agree because this experience that you had, or whatever. So, so there's kind of a lot of different things there. So when you go into the assignment, you should be able to click on the three dots on the upper right corner, and it'll say show rubric, and it's going to show you exactly how you're graded.
All right, guys, does anyone else have any other questions before we end class? All right, well, be on the lookout for my week 3 announcement on Saturday. Don't hesitate to reach out if you have any questions in the meantime. Reaching out to me in Canvas is perfectly fine, or on email, okay? Um, and then, like I said, Professor McBride should, by the end of this week, post the exam one review sessions. So you guys can look ahead and plan for that too, okay? All right. Thanks, everybody. Have a good night.
Thank you.
Thank
Too.
you.
Yeah.